Do you dare make a change? Challenge fixedness. Be an innovative thinker. Do you dare to change? These are the people who dare. Dare to question. Lead innovative research. Develop outstanding practices. And find new ways to make a change. Sheba Medical Center. Talpiot xmed 2022.
שלום לכולם, ממש מרגש לראות את כל האנשים כאן. אני כמובן נעבור לשפה האנגלית, יש לנו המון צופים מחול שמסתכלים כרגע בשידור חי. So good evening and good morning to our friends across the globe. It's a privilege for me to be opening the second Talpiot xmed event, and for the first time as an open audience event. I'm Professor Eyal Zimlichman, and I serve as Deputy Director General, Chief Innovation Officer, and Transformation Officer at Sheba Medical Center. I'm honored to also serve as head of the Talpiot Medical Leadership Program at Sheba. Talpiot xmed is an international event taking place live on stage here in Israel and broadcast to over 17 countries. Our first event was during the COVID pandemic, and the only way to share our achievements with you was online. I'm glad we have this opportunity to host so many of you here in Tel Aviv. We have a very engaging program for you today, featuring a taste of what Talpiot actually is, sprinkled with generous amounts of the famous Sheba spirit. Let me tell you a bit about the Talpiot Medical Leadership Program. As a Talpiot graduate myself from the third cohort, standing here takes me back to sometime in 2007 when I was accepted to the program. I remember how proud it made me feel to be a part of this community, but also the feeling of responsibility, becoming an integral part of something bigger than myself. Now, Sheba Medical Center has always put the individual first, offering several programs of excellence that identify, educate, and promote the finest. Among those, Talpiot stands out as the absolute best, a promising group of young physicians who are selected and cultivated to lead the future of healthcare at Sheba, in Israel, and around the world. Just a month ago, we selected the 10th cohort of bright, committed, and very young medical leaders, the top 10 of a top 10 hospital. I know most of them are sitting here in the audience. The Talpiot program is based on two main pillars: leadership and excellence. For excellence, there's a personal development compass covering four main areas we work on with every Talpiot member: clinical skills and patient care, engagement in significant research, and leading through innovation and entrepreneurship. For leadership, physicians learn the skills needed to lead institutions, departments, and teams in order to achieve shared goals and outcomes. We are now 85 members, and many already lead with significant roles in the Israeli health ecosystem. Just one example, the directors of oncology departments in Israel's 5 major hospitals are Talpiot members. I guess most of you never knew that, right? I think you will agree that Talpiot is already leaving a substantial footprint. And today, 5 Talpiot fellows and a representative from Telem, Talpiot's sister program of excellence in leading researchers, will share their cutting-edge research, insights, and pioneering work. You can only imagine how difficult it was to choose only 5 fellows out of all Talpiot members when all have interesting and outstanding findings to share. You'll just need to come back in the years to come and hear that there's plenty more where this came from. This is the perfect moment to say thank you to all partners in the Talpiot program. First of all, to Harry and Talia Gross. Without whose generosity this program would not have been possible. To Sheba's leadership across the years, who have made Talpiot a reality, and to Sheba's Director General, Professor Kreis, for his vision. You'll hear from Itzik later on. To the Talpiot Steering Committee, always providing us direction on where next to take the program. To SIT, Systematic Inventive Thinking, for their ongoing role in running the program since its very early days. And finally, to all Talpiot graduates and members throughout the years, continue to lead, discover, deliver outstanding care, and above all, dare to change. And now to the main event. But just before, I'm honored to present the person whose generosity and vision enables Talpiot, Mr. Harry Gross.
Program is hosting an xmed event. By now, this is a tradition that my wife Talia and I are honored to take part in. Moreover, everyone present in today's event in Israel and all of those participating from around the world should also be proud of the accomplishments that the Talpiot members have achieved. Sheba has committed itself to build and develop a leadership program that impacts the health ecosystem nationally and internationally. This is a program that encourages and supports physicians to develop their qualities of leadership, innovation, entrepreneurship, research, and clinical performance. And this program delivers results. There's nothing more gratifying than knowing that physicians that are members of the Talpiot program have become leaders of hospitals, departments, and research centers. Let's give a round of applause celebrating the achievements of the Talpiot members. On a personal note, I had the opportunity to meet from time to time Talpiot members. These one-on-one meetings for lunch or dinner impressed me again and again as how motivated each and every one of them is to achieve the program's goals, to lead, to innovate, to find creative solutions, to make a difference. They just don't give up. Professor Kreis and Professor Zimlichman continue with determination to encourage and promote this exceptional DNA that inspires original thinking, curiosity, healthy doubtfulness, entrepreneurship, and innovation. The result is a culture of search for excellence and dare to change. My wife Talia and I are in awe and humbled by the quality of the program and take this opportunity to wish all the new Talpiot members much success in their endeavors. Alu v'atzlichu.
Since I was young, I looked at things differently. I constantly need to be in motion, to move from one spot to another, but to do it in a unique way. I found this sidecar in a flea market in Mumbai and instantly knew it should be mine. And it is for the past 17 years. Hi, I'm Professor Ido Didi Fabian, I'm an ophthalmologist specializing in eye tumors. I treat here in Sheba little babies with an eye cancer called retinoblastoma and constantly look for new ways to investigate the disease. A few years ago, I founded the Global Retinoblastoma Study Group, and today it includes most specialists from most countries across the world. Together, we are trying to unveil the world of retinoblastoma and help those little kids from all across the world. And this is what I'm going to talk about today.
Please welcome to the stage Professor Ido Didi Fabian.
Imagine a flat world, not by physical shape as perceived in ancient cultures, flat as an equal opportunity to all people and all children, regardless of where you were born or live. Retinoblastoma is a rare, potentially deadly eye cancer in infants caused by a genetic mutation. There are about 8,000 newly diagnosed cases every year globally. This smiling child has retinoblastoma. You can appreciate the white reflex in the left eye, which is a common first sign. You know, in order to perceive an image, light needs to go through a clear media until it hits a light-sensitive layer, the retina. This transparent route allows us ophthalmologists to look inside our body, see normal structures and pathologies such as this early stage retinoblastoma. Now, why potentially deadly? Because in the 21st century, retinoblastoma is in fact a curable disease. Children are diagnosed early, successfully treated, and they survive with some disability, but they make it, like that child. This was the state of mind I grew into professionally during my training years. But things changed in mid-2017 when I received an invitation to join the Retinoblastoma Network, a group of specialists in the field from the UK, India, and several countries from sub-Saharan East Africa. There was a meeting taking place in Hyderabad to discuss how to improve the care of children from the African countries. That is where I first understood that what we actually know about the disease comes from rich countries, from North America, Europe, Israel. But globally, less than 10% of the children reside in these countries, whereas most live in poor countries in Asia, Africa, and Latin America. How does their retinoblastoma look like? Do they survive? Do they hold an equal opportunity? Apparently, at that time, we had no answers to any of those questions. Is the world flat? It would be important to find out. So I went on a long voyage to recruit all retinoblastoma treatment centers across the world to share data, study the disease, and collaborate. Eventually, by the end of 2018, there were 300 centers on board and nearly 4,500 children enrolled from 153 countries. That is more than half of the annual global incidence of the disease. If a picture is worth 1,000 words, a video is probably worth much more. Here. "18 months in 10 seconds. The first study was very simple. We asked, how does a child with retinoblastoma look like at presentation in London, Lima, Lagos, Lahore, and Lviv. We also included cities that do not start with an L. And what did we find? We found that nearly 100% of children from high-income countries present with the tumor confined to the eye. In low-income countries, in contrast, half of the children present with the tumor that has already escaped outside the eye. Now, we know that in some cases, retinoblastoma is inherited by an affected parent, what we call familial disease. In others, it develops de novo, first affected subject in the family. But some of those children, in time, will bring new babies with retinoblastoma. What we found in our global analysis is that children from low-income countries had 3 times less the rate of familial disease compared to those from rich countries. The explanation taken directly from Darwin's Origin of Species: only the fittest survive. Children from poor countries present late for various reasons, too late, and they do not make it to childbearing age. We also compared Europe to Africa, and not only because both continents are on the same strip. Apparently, in Africa, only children that reside in proximity to the treatment center eventually reach it. Only those within the red circles, which represent the exact location of the centers. Many are left at home to die. From the center's perspective, imagine a blanket that is supposed to cover the entire continent, but in fact has many holes, more holes than fabric. In Europe, the blanket is nice and warm and big enough even to cover parts of North Africa. But furthermore, we did some incidence calculations. Retinoblastoma is like a manufacturing defect in a factory. The mutations occur in a constant rate. This is the known rate for many years. True? Nope, not in Europe, where we found a higher than expected incidence. The disease is more common than we thought. In Africa, the strong survive. In Europe, the weak survive too. Early diagnosis, effective treatments, and the genetic pool of retinoblastoma is on the rise. 2020, and despite COVID, all centers from all countries, still glued together, report the 3-year survival of retinoblastoma, to find out, sadly, that George Orwell was right. All are equal, but some are more than others. Nearly all children from high-income countries survive, as compared to only half of those from poor countries. Let me put this in numbers. If you were born in Malawi and diagnosed with retinoblastoma, you'd have 17 times increased risk to die than if born in North America. As in any scientific experiment, first measure the baseline status, then assess, intervene, reassess, and continue moving forward. It's a long journey with numerous challenges, and it takes time until an impact is seen. We're collaborating with the WHO, the World Health Organization, and are in continuous interaction with local governments. Uganda, for example. Share knowledge, create new treatment centers, discuss policies, train local doctors. 2 years ago, we started a project to link local centers and international experts by telemedicine, having monthly online meetings, tumor boards, discussing challenging cases. Not only Uganda, Anglophone, Francophone African countries, outside Africa as well. Politics is not an issue. On the contrary, we are bridging the gap. Pakistan, Iran, there are no borders. We are witnessing today a global genetic revolution. Flat world, remember? We're introducing genetic testing in African countries and link between geneticists from rich countries with local doctors to assist in family counseling. For retinoblastoma, this is a game changer. Just the other day, I ran into a short piece in The Guardian in which readers replied to the following question: if the earth were flat, how would our lives be different? There were dozens of replies. One reader rightfully said that mountaineering would be a lot safer. Others claimed we would have a load of conspiracy theories trying to convince people of a globaler Earth. But I related mostly to, what do you mean if? Thank you.
Since I was a child, I always wanted to do, and I challenged myself again and again and again. When I was 20, I had my own dance studio in Jerusalem, and 4 years later, I choreographed the national opening ceremony of the Independence Day, which was broadcasted live on TV. I wanted to learn how to surf. I had to dare myself to go into the water and take those big waves, and I did. Hi, I'm Dr. Abigail Livni-Ezer. I'm a neuroscientist, neuropsychologist, and neuroimaging expert, a member of the TELM Excellence in Biomedical Research Program. I'm at the head of the Diagnostic Neuroimaging Laboratory. I believe MRI scans analyzed with our unique image processing and artificial intelligence algorithm will change the way the neurology and psychiatric fields work today. I opened a neuroimaging laboratory at Sheba Medical Center. I built an amazing team to develop image processing, neuroimaging analysis together with AI algorithms. During our research, I challenged my team to offer our algorithms as service to the hospital to aid neurosurgeons define their path of brain surgery. My research is all about changing the way we diagnose and treat brain disorders patients, and that's what I'm here to talk about.
Please welcome to the stage Dr. Abigail Livni-Ezer.
I would like to tell you about two of our patients. The first one is Gali. Since COVID, she has lost the desire to go out of her home. Recently, she quit her job and dropped out of her BA studies. Gali was diagnosed by a psychiatrist as suffering from depression and was prescribed with antidepressant medication. But few weeks later, she still felt like there was nothing worth waking up for in the morning. Dan, the second patient, climbed on a chair to change a light bulb in his bathroom. He fell and hit his head on the bathtub, lost his consciousness for a few seconds, and woke up to a terrible headache and blurriness. Dan was examined in the emergency room by a neurologist and performed a brain CT scan, which did not detect any brain abnormality, any bleeding, and Dan was diagnosed as suffering from a concussion. Gali and Dan were recruited to participate in my studies, and both patients performed a brain MRI scan. What is the common thread between these two patients, aside from participating in my studies? Well, let's have a look at their brain scans. They look normal. The psychiatrist, neurologist, and neuroradiologist did not detect any brain abnormality, and their scan reports were defined intact. But I ask, is this true? Are the tools we have today sensitive enough to detect specific brain diseases? As every person has his unique facial characteristics and unique fingerprint, so does every person has his distinct brain neural print, a concept called the connectome, which is a map of the individual's specific brain connections. Imagine what if certain brain diseases, such as depression or concussion, had their own specific connectome. Our vision is that we could learn the specific pattern and unique neural print of a particular brain disease by looking at patients' personalized connectomes with artificial intelligence. In the field of brain diseases, in particular in neurology or psychiatry, there is a lack of tools for objective diagnosis, outcome prediction, and personalized medicine. Therefore, we developed a system in which a patient with a query of brain disease will perform a short MRI scan. Our system will then produce the individual's personalized brain connectomes, insert it into our special machine learning artificial intelligence model. That, in turn, outputs a diagnosis, predicts clinical outcome, and recommends optimal treatments. So, how does the system work? MRI can be used to scan both structure and function of the brain. Structural MRI scans follows the pathway of our neurons, creating a map of white matter tract which connects one area of the brain to another. This is the structural connectome. Functional MRI scans follows brain activation, mapping the joint activity between different brain regions forms the functional connectome. The use of the two types of connections in our system is of great importance, since the multimodality aspect is imperative to get a comprehensive view of the brain. Imagine a diagonal line on this image. Looking from one point of view, one can think this is a horse, and from another, a person. But only the combination and integration of the two perspectives will give us the full, true picture. Remember Gali? Using our system, we were able to diagnose Gali and other individuals suffering from depression with an exceptionally high accuracy of 88%, something that the physicians or any other medical tests were not able to do even on the basis of these patients' brain scans. After Gali's MRI scan, she was prescribed with antidepressant medication, and we followed her and other depressive patients for 8 weeks, the time it takes to feel relief in symptoms. Based on our pre-treatment personalized connectome, we were also able to predict which depressed patient will respond to medication 8 weeks later with a high accuracy of 91%. Again, incomparable to the standard today. This time, the medication Gali received was a good fit. She responded to the treatment we recommended her based on her connectome. Most patients aren't that lucky, since only 1 out of 3 patients will respond to the first line of medication. Our system will allow us to guide physicians to prescribe the best fit medication for each patient from the start, thus preventing prolonged suffering. What about Dan? We were also able to diagnose Dan and other patients as suffering from concussion with an extremely high accuracy of 93%. The interesting thing is that when looking only at the structural or only at the functional connectome, we received lower accuracy rates than from using the multimodal connectomes, emphasizing the integration of both brain structure and function. Dan, like other concussed patients, was at high risk to suffer from cognitive deficits post his head injury. So we clinically followed him and other patients for a period of a year, and were able to predict clinical and cognitive outcome of these concussed patients a year post-injury. Thus, based on our prediction, we could recommend cognitive intervention for a more optimal treatment. On a personal note, a few months ago, my brother-in-law called me after he had an accident during riding his bicycle. He hit his head badly and was on his way to the emergency room. I was shocked. He was on his way to a different big hospital, not Sheba. So I urged him to immediately change his destination to Sheba, of course, and met him there. After both the neurologist and radiologist examined him and his CT brain scan, I was assured he is okay, and he was discharged. The next morning, he called me and said he had the worst headache ever. He was confused, and he was disoriented. I rushed him back to Sheba, worrying that we missed a hemorrhage in his brain. This time, we scanned him with a standard clinical MRI scan. And again, I was reassured his brain looked all good. Sure enough, our novel system recognized him as a concussed patient and not as a healthy participant, based on his connectome. So, then what next? Almost every person knows a person who suffers from a type of brain disorder, such as Alzheimer's, pain disorders, post-traumatic disorders, or even ADHD. Our innovative system can be used as a platform for diagnosing and personalizing effective treatment of these and other neurological and psychiatric diseases. As Albert Einstein once said, a great thought begins by seeing something different, with a shift of the mind's eye. Thank you.
Basically, everything I do is because I'm bored and I need new challenges and new stimuli. Hi, I'm Elad Jacobi. During med school and after, I fell in love with pediatric oncology. This is treating children with cancer, and it's a true opportunity to make an impact, a change in someone's life. Also, it combines state-of-the-art science in daily practice. About 10 years ago, I studied a new form of therapy called CAR T cells. I love taking things from the idea, the concept in the lab, and finding the ways to put them in the process to take them to patients, to translate what we see in the lab in the science to patient care. This requires looking at the big picture and working in interdisciplinary teams with people from the lab, clinicians, nurses, social workers, and much more. And today, I invite you to my talk called Tea Time.
Please welcome to the stage Dr. Elad Jacobi.
One of the worst moments for a parent is when he or she hears that their child has cancer. And even worse, when the cancer has come back when previous therapies have failed. I'm a pediatric hemato-oncologist, and I treat children with cancer, mostly leukemia, a cancer of the blood or marrow. Now, leukemia was a deadly disease in the 1950s, but I want to tell you that with modern therapy, most children are cured. However, for a disease that unfortunately returns, we want and we need to do better. In recent years, a new form of therapy was introduced to the world of cancer, immunotherapy. You may have heard of it, with a Nobel Prize recently awarded to two scientists who managed to enhance the body's immune response against cancer. But for childhood leukemia, this form of passive enhancement was just insufficient. A decade ago or so, when I started my training in the National Cancer Institute in Maryland, a new form of therapy was implemented using T cells. These are the most powerful cells of our immune system that usually fight infections. For treating leukemia, we needed to re-educate these T cells actively and help them target the disease. We learned how to take this powerful immune soldier that knows from years of evolution to fight viruses, bacteria, and more, and target it towards leukemia. This is like adding targeted missiles to the patient's own immune cells through genetic engineering, teaching them to attack specific cells and sending it to destroy malignant leukemia cells. Surprisingly, this worked. We were astonished to see patients that had failed many therapies suddenly have all their disease cleared only with this immune manipulation. So we had to rapidly implement this therapy in Israel. Now, this was not a simple task. It was quite a challenge. We're not talking about a drug you can pick off the shelf from your pharmacy. This is a personalized therapy. We had to learn how to collect the immune cells from the patient, take them through heavy manipulation in the lab, and administer them back to the patient. For this, we needed lab technical state-of-the-art knowledge. No one in the country knew the process in which T cells are re-engineered or re-educated. We needed clean rooms in which we can safely work on cells, making sure that they're not contaminated through this long process. We needed clinical training for pediatricians, hematologists, nurses, ICU teams, and more to introduce them to these new therapies and their potential risks and benefit. And we needed regulatory approval of this high-tech interventional therapy to make sure that we can actually grow T cells outside the body and safely transfer them back to patients. Sheba was one of the first institutions worldwide to deliver locally produced CAR T therapy to patients. This is thanks to excellent people and fast adaptation of staff and infrastructures. So now we had a new tool for leukemia when all previous therapies have failed. We treated the first patient, a child under my care, back in 2016. This child is now 6 years later and doing well. And we have since treated more than 200 patients, children and adults. Let's take this one step further and see where we're aiming at. Sometimes leukemia resides in the brain. It hides them from all the therapies that we give. You can see it here. The bright rectangular shape on this brain image is actually a leukemic mass. Early on, we assumed that T cells, as they can go into the brain to treat infections, may go there also to treat cancer, only if we help them a little bit. So we took upon ourselves to treat children with leukemia in the brain, and we could indeed see that these novel cells cleared disease that resided there. In the future, we want to be able to provide therapies using re-educated T cells for more diseases. We want to target brain tumors in children, as these are extremely difficult to treat. After proving that re-educated T cells can kill cancer cells and they can enter the brain, we are in the process of finding the right targets in these tumors. After all, this is tea time. Thank you.
Since I was a child, I just couldn't stand still. I just needed new input every day. When I see a problem, I just need to solve it. I was always initiating processes. A good solution makes a change. Living in Italy made me fall in love with antiques, history, and art. Many things are symbolized by this bag. Doctor, Italy, history. My name is Professor Haik. I'm the director of the Division of Plastic Surgery and Burns. I'm also the head of the National Burn Center in Israel, and I'm the medical director of our new Bank of Skin and Skin Lab. Skin is one of the most important organs in our body, and it's also the biggest. As a plastic surgeon, we always seek to reconstruct our skin and soft tissue defects. So we created a lab that can grow it, can develop it, and we will find the solution at the end.
Please welcome to the stage Professor Joseph Haik.
As a plastic surgeon, my real passion was always to treat and reconstruct burns. One of my dreams that I managed to realize was to build the first National Burn Center of Israel at the Sheba Medical Center. A few facts. Burn Center is a very unique facility. It is the only one in Israel. Burn is one of the most complicated human body injuries caused. It involves the skin. The skin is the biggest organ in the human body. Imagine that if we spread all cells of the skin, we can cover a soccer field. The skin has two components, epidermis, which is the superficial layer, and that acts as coverage, and it permits us the life. The dermis is just right under and functions as a support. It gives the quality of life and the quality of scarring in the long term. Our own skin can be replaced only by our own skin and its components. The skin is critical for life. Without the skin functions, all our systems enter in a vicious circle that can bring to death. The skin offers body coverage, fluid and electrolytes retention, temperature maintenance, sensor system, and even immune system. So, in the quest for replacing our own burned and damaged skin, we always try to bridge the gap by expanding and creating coverage with our own remaining skin. We knew that finding the skin from other resources are all temporary solutions. Burn prognosis is not favorable, and yet saving life is our first mission as medical doctors. To better understand the big picture, there is a score that tries to estimate the prognosis, where age plus percentage of burn should not exceed 100. Lately, we treated a 27-year-old veteran that had a challenging burn injury caused by fire, extending to 98% of his body. The only soles of his foot remained with normal skin. They are estimated as 2%. That means that we had to gap 98% burn with these 2%. And that means that he had a low chance to live, if at all. So let me take you on a journey trying to save patients' lives. Throughout the years, we tried to get temporary coverage from different animals. The first was a pig, then frogs, and even fish. But these are all temporary solutions to gain some time so we can get the definitive coverage with the patient's own skin. We try to expand patient's own skin by meshing, increasing each graft size into up to 6 times fold, but it came with a long healing time. In addition, we needed multiple surgeries and to wait between those until we can harvest skin again. Another technique is the MIC technique. Using this technique, we created dots of skin, and then they can be expanded up to 9 times. But again, we need to wait for a long healing between the dots that will grow and unite with time. So the only way to find available skin, almost with no limits of size, quantity, was through growing skin, the patient's own skin. The first phase was to build the epidermis, the upper layer of the skin, as I said, that permits us life. Howard Green, the father of cell cultures, donated and helped us to build the first green lab, skin bank, at the Sheba Medical Center. It is a unique, good manufacturing practice lab that permits us today to grow this upper layer almost with no limit. From a small biopsy of 1 by 1 centimeter, today we reached, in the veteran case, almost 650 small sheets of epidermis. Each is less than a palm of a hand. We managed to create epidermal sheets covering almost a surface as large as a dining table. That allowed us to save the veteran's life. The cells we grow and bank, in the veteran case, for example, can be seen as immortal. Whenever there's need, we can reuse them and grow them again. But in the quest of skin, we still have to improve the quality of the skin that we grow. So we need to look for a dermis layer. Today, relatively new techniques enable us to spray cells to allow significant expansions of the cells on large surfaces. But spraying does not permit us to see or to be sure that the cells adhere or remain even in place. The sheets we grow today are limited in each piece size and are hard to apply and handle, while requiring a long, complex process of manufacturing until it reaches the patient. So, seeking for a better solution, we at Sheba introduced electrospinning, a technology that is in use for other purposes. We miniaturized a huge, clean lab into a handheld mobile device that permits us to weave a nanofiber personalized tissue, printing it on the patient with his own cells. During the application, there's no pain because we don't even touch the patient. There is a full adherence, transforming dressing process into a bedside personalized printing of epidermal substitute. It permits us to use a 1 cc ampule that contains millions of cells and transform them into an A4 cover sheet of epidermal substitute. It is 6 times fold compared to the sheet of cells that we were able to create up to date. In the veteran case, where he had almost undamaged skin, we still used his own cell suspension in combination with the electrospinning device, saving time in the process of making sheets from the biopsy. We improved and shortened the time of cell expansion in the lab and made it easy to handle. We saved the veteran's life. The electrospinning matrix mimics the patient's own skin dermis, and now the veteran is already in rehab. But the quest continues. We grow skin on chip, learning how skin behaves without even using animal experiments. We challenge immune concepts, trying to find universal skin. We even consider sending skin to International Space Station because we think we can grow skin even faster and better in space environment. We always look for new horizons in the development of skin and skin substitutes, applying existing knowledge and exploring the future. We continue to seek a new equation of saving lives and improving quality of life. Thank you.
I like to sing, I like to dance, I like to move. I throw amazing parties. I'm a nature lover. I need to be in the open air, and the place I'm really happy in is in the water. I was born in Sheba, so it was only natural for me to become a doctor. I celebrate life, and I usually remind everybody how beautiful life is. Hello, I'm Dr. Einav Galyam, head of the Breast Oncology Institute. I became an oncologist because of the unique combination of long-term personal patient care and cutting-edge research that this medical profession offers. I've established a research lab studying various aspects of breast cancer and its treatment. For 10 years, I've headed the Oncology Ambulatory Care Department, where we made leap changes in virtually all processes involved in patient care, flow, and chemotherapy treatment. For years, I worked alongside Professor Bella Kaufman, who was my mentor. I've learned so much from her. She was soft-spoken and calm, but she always knew and she achieved what she strived for. When I became head of breast oncology and the integrated breast cancer practice unit, I put an emphasis on a multidisciplinary teamwork, which I believe is one of our major strengths. Today I'm going to speak about the IPU model and its impact on us and our patients.
Please welcome to the stage Dr. Einav Galyam.
Imagine, what if every time you want to know what time it is, you had to combine the cogwheels in your clock so it will work right? It is complicated, time-consuming. You're not even sure how to do it, and you might just get it all wrong. But this is similar to what a patient diagnosed with breast cancer had to go through until recent years. My name is Einav Galyam. I'm a breast cancer oncologist at the Sheba Medical Center. Today, I will tell you how we changed the way we treat our breast cancer patients by working as an integrated practice unit, and how this has impacted their journey and their outcomes. A woman can be diagnosed with breast cancer by various ways. Through a routine screening mammography, because she or her doctor feels a lump in her breast, or rarely because of symptoms of metastatic disease. No matter how the diagnosis was made, patients describe their feeling when they hear that they have cancer as if the sky has fallen down on them. They have met the emperor of all melodies. And this melody is a complex medical situation. It is scary and confusing. There are so many things to be done, so much information to be gathered. It needs surgery, medical oncology treatment, radiation. Sometimes plastic surgery is in place. All pathology details have to be gathered. Radiological exams have to be performed. Sometimes we need to know the genetics, as it may change the treatment course, or for young women who will want to bear children in the future, fertility preservation and a gynecologist consult may be needed. And there are financial and family and psychological issues. Will the patient be able to continue working throughout her treatment? What should she tell her elderly parents, her young children? How? She needs guidance and comforting. So you understand, to achieve the best results, which are cure and preservation of the quality of life, breast cancer needs to be treated by numerous specialist healthcare providers, and the clock is ticking as time makes a difference. The sooner the cancer gets treated the right way, the better are the results. Previously, the patient would have started her journey by going from one specialist or one silo who referred her to the next one in a linear fashion through various administrative procedures. And while every specialist is excellent, a perfect cogwheel, each one worked separately and spoke a different dialect of the medical language. And so his or her part of the story from their own perspective, similar to those blindfolded people who are describing the elephant differently through touching its different body parts. It impacted the whole journey. Moving from one specialist to the next might have taken too long, or an important exam or procedure could have been missed or performed at the wrong time. The patient did not have enough information on how to navigate the whole process. The machine did not work in an optimized manner. We aim to change this. We transformed our treatment model to that of an integrated practice unit, or in short, IPU. IPUs are defined as those which provide highly coordinated multidisciplinary care centered on a specific medical situation along its entire clinical course, from diagnosis, through active treatment, through survivorship. This course can span years. How did we evolve into an integrated practice unit? We started years ago. In simple coordination between the various specialties, all of us meet in dedicated weekly multidisciplinary meetings where we discuss each patient's case and together reach a conclusion regarding the best way of action. Should this patient have surgery or medical oncology treatment first? Do we need to gather additional radiological or pathological or genetic information to proceed? Is the intervention of a social worker or psychologist in place? When we sit together in the same room, and for the last 2 years in the same Zoom, we start to talk in a similar language. We can see each other's perspective, and we make much better decisions this way. However, while joint decisions made in the multidisciplinary board are essential, they are useless if they are not executed in a timely and efficient manner. So we cooperated to take this multidisciplinary work a step further. We sit together, representatives of all disciplines, discuss and map the different treatment pathways our joint patients going through, and we define the gaps in these pathways. We measure time intervals of the various processes, the time from surgery to a pathology report, to a meeting with the oncologist, to receiving chemotherapy. We analyze the causes for delays. We ask our patients what they are missing during the treatment course and at what stage. We defined which additional healthcare and administrative personnel or technological or digital tools are needed to better fulfill their needs. So, what did we achieve so far? Here are some examples. Practically all of our patients' cases, 100%, are discussed in our tumor boards to reach joint decisions, which are efficiently executed by nurse and administrative coordinators. We implemented digital and administrative tools to improve efficiency. This resulted in reduced timelines of about 30%, while patient numbers and procedures have concomitantly increased. Additionally, it made processes much more transparent to the patient. Each of our patients is proactively contacted by a social worker and, if needed, has access to our in-house genetic counselor, gynecologist, dietitian, psychologist. And we developed information resources and digital tools to aid our patients navigate their journey. One of these is our symptom management application. So, if you're a patient undergoing chemotherapy, you will be sent a weekly digital questionnaire to your smartphone asking about various symptoms that you might have. If you report a symptom above a specified threshold, an alert is raised, and a dedicated nurse will contact you to find out what is happening and to instruct you how to proceed. This kind of management tool has shown to improve patients' quality of life and even survival. And we remember that even when the active treatment is done and everybody is happy, this is not the end of the journey, as many years of survivorship lie ahead. For these, we are implementing various programs dealing with physical, cognitive, and emotional long-term effects of the treatments that we gave our patients. But for me, I believe what made most of the difference is the fact that this process has indeed transformed us to become an integrated unit. We are working and cultivating collaboration. Everyone teaches and everyone learns. And we assume positive intent as a coherent team dedicated towards the same goal. We are bringing extra value for our patients, and we bring extra value for ourselves in the meanwhile. This is us, an excellent team treating breast cancer patients. We have come a way, and we still have a way to go. So when you go home today, wherever you work or operate, ask yourselves, what are the measures that you can take to combine the cogwheels around you into a perfect running clock? Thank you.
Daring is a part of my everyday life. I like to try new things and I step out of my comfort zone. When I'm off duty and I try to unwind, I listen to rock music and podcasts about history, economy, and philosophy. I'm doing everything I can to live a life worth living. Hi, I'm Ariel Tesson, MD, and I head breast reconstruction here at Sheba Medical Center. As part of stepping out of my comfort zone, I tried plastic surgery and loved it. In surgery, we're always looking for ways to reduce OR time. It makes for better surgery and reduces the risk of complications. As an outcome, we recently discovered a way to reduce 25% of our OR time in our most complicated operations. The time is right for the next big leap in the surgical point of view. And today I'll be speaking about how virtual reality technology helps us deliver better and safer procedures to our patients.
Please welcome to the stage Dr. Ariel Tesson.
Agriculture, industry, communications. What do these three have in common? These are the three momentous revolutions that changed the world we live in. But there's another revolution coming, the virtual revolution. Lately, we're hearing a lot about the metaverse, NFTs, and of course, the big star of virtual reality, gaming. This is my daughter, she's here in the audience with us. But virtual reality is more than just an online experience. VR is also changing medicine. We can use VR to plan and train, but most importantly, we can tailor procedures specifically for each patient. For instance, at Sheba, we can use VR to assess defects in the heart and decide if a patient needs surgery or not, or to image the GI tract. And here is VR being used in the pain clinic to manipulate nerves and relieve pain. As you can see, the future of VR in medicine is huge. But let me dive in and show you how we overcome one of the greatest challenges in breast reconstruction for women who have breast cancer using VR. This is a silicone implant. We use it in breast reconstruction to give volume to the reconstructed breast. It's good, it's very good, but there's something even better, the patient's own body. And for the last 2 decades or so, we in Sheba have been able to build a full breast from the patient's abdominal wall, the tummy, and get the most natural results. This is a very technically demanding procedure that relies on our ability to connect tiny blood vessels around 1 to 2 millimeters in size from the abdomen to the chest. Now that's great surgery. But one of the greatest challenges in this procedure is actually finding these tiny vessels. It's literally a needle in a haystack. So let me give you a challenge that demonstrates the experience of finding those tiny blood vessels. This is an aerial photograph of Tel Aviv and Jaffa. Try to find in that picture the most well-known bakery in Tel Aviv, Abulafia Bakery. It's there, I promise. But it's nearly impossible, right? There are a few things, however, working in your favor. You know what a bakery looks like. It will probably have a large oven, maybe a counter, just as we know what the vessels look like. But that's not enough. It's not even helpful, is it? So we try to make it a little bit easier by adding Doppler mapping. Now, Doppler uses ultrasound technology to detect blood vessels, but it doesn't give us the exact location, the size, or the route the vessels travel in. It's a little bit like saying, I can smell fresh bagels in that neighborhood painted in red over there, so Abulafia Bakery must be there. It's better than nothing, but that's that. The next phase was to get a CT or MRI scan that actually shows the vessels. Now that's a substantial leap forward. It's a little bit like giving you the address for the bakery and handing you a street map. But that sounds so obsolete, right? So 90s. Why can't we use maybe a GPS app or something with live traffic? And that's a little bit like using a 3D model. And that was the best we had until recently. But our aim was to develop something way better, something that would fit our modern life. And for that, we partnered with an Israeli high-tech company, recruited a research student, and went to work on setting up a VR system specifically designed for this purpose. It wasn't easy, there were a lot of details, but we got there. Here you can see me preparing for surgery, seeing not just the location of the vessels, but other valuable information as well. I can decide based on the patient-specific model which vessel is the dominant one, see the route that it travels, all the twists and turns, the junctions and the pitfalls. It's like navigating to the bakery after you've been there already and know the way, and that's amazing. And here, you can see the same technology in the OR, and you can see a reflection of our student over there. So in just a few short years, we actually went from this aerial photo to this. We are now conducting a study that will demonstrate the power of this technology, but I can already tell you that we're able to cut OR time dramatically with this tool. And this will be useful in other fields as well, such as orthopedic surgery, pain relief, rehabilitation, treatments for anxiety, neurosurgery, and much, much more. But it gets even better. Imagine what if we could do this in real time. See the hidden tiny vessels for each patient during the operation itself. And this is our next goal, augmented reality. Now, obviously, this is a game, but this is not. Here you can see pictures from our pilot study. It's not ready for prime time yet, but it will be. We aim to make one of the most challenging and demanding procedures in all of medicine easier to perform, shorter, and with less complications, so that more patients can receive the best surgery available. Technology is the greatest enabler we've ever known, and this is my dad trying VR for the first time. Thank you very much.
Please welcome to the stage Director General of the Sheba Medical Center, Professor Yitzhak Kreis.
Can I get some light to see the people? I'm not going to stand in the MEDEX circle. I'll move more, and I won't use what I prepared. I just talk from what I feel. Every day, I am proud to be the CEO, the Director General of Sheba Medical Center. Every day. Even in the worst days. But sometimes I feel prouder. And to listen to what you just presented, to see your charisma, your commitment, your wisdom, your professionalism. Makes me even prouder. So this type of days is days that I feel more proud with being at Sheba. I feel younger because they told me to come with jeans, and I'm like all the young presenters. But I want to share with you what is Talpiot in my eyes. You know what it takes to be a physician in Israel. It's even more, excuse me, even more than rocket scientist. I apologize. What it takes to be a physician in Israel. You have to be at the edge, in the cutting edge of the human capital in Israel. Some would say that even you have to be selected to be an Israeli before you are, there's gonna a selection process to be an Israeli, to live here, before you get selected to be a physician. So after you've been selected to be an Israeli and live here, and you've been selected to be a physician, now to be accepted to a residency at Sheba, it's about 1 in 10. 1 in 10 of those that were selected to be Israelis, that were selected to be physicians, is accepted to be a physician at Sheba. And then from those, it's about 1 in 4 to stay at Sheba. And from those, 1 in 40 to be selected as a Talpiot member. So, do you know, and we are talking about Israelis, do you know any kind of selection process that brings to the tip point the best people in the world? And we are very, very lucky because we have those people at Sheba, those people at Talpiot program, those people here. And combined to that, the best infrastructure in the world. Combined to that, patients, data. Combined to that, the need, the aspiration to be better, the aspiration to heal. And combined to that, another very important feature, the chutzpah. The chutzpah. The character to dare. And this is Talpiot. So we have everything we need to be the best in the world, to change, to dare to change the future of medicine. And this is what is Talpiot in my eyes. In order to do that, you have to understand what excellence is, and many institutions in the world knows what excellence is. That's fine. You have to have innovation spirit, and many other institutions in the world knows what excellence and innovation is. But one of the most important qualities in order to bring dare to change to reality, vision to reality, is leadership. And this program is also about leadership. And you've seen today Avigail Ezer Livni, Didi Fabian, Einav Galiam, Ariel Tisona, Oad Yacobi, Yossi Hayek. Guys, you're a great performance. I didn't know that you are. So you see them, so you understand what excellence, innovation spirit, and leadership means. I want to thank Ari and Talia are on Zoom. I don't see you, Talia and Ari, but I want to thank you from here. You are not only supporters in material, you also support us in your spirit, in your smart ideas, in your direction. So we are committed to the success of this Talpiot program. Thanks to you. Thank you very much. The girls, Ari and Talia. Thank you very much. 10 years ago? No, 11 years ago. I called a Talpiot member. Sat at my home and told him I was selected to be the Surgeon General of the IDF, and I needed the best people to stay at the IDF. So I called one of the Talpiot members to my house, interviewed him, and said clearly to him, leave Talpiot and go back to the army and work with me in the IDF. And he said, no, I'm a Talpiot member, and it's a higher commitment to stay a Talpiot member. And this guy is Eyal Zimlichman. I appreciate that you refused 11 years ago. I want to thank you for leading the program, being the spirit behind the program, being the role model for all those Talpiot members. Thank you very much for what you've done here. I thank the people who conducted the evening and conducted TEDx. We are going, MedX, we are xmed. We are going every year to raise the bar even higher every year. So next year, on a space shuttle, we can do it on a space shuttle, transmit it in Zoom, so think what is the next idea. We have to go back. Many of the Talpioneers here, some of them have, especially Itai Pesach, have to rush to Sheba because we are now transplanting these very moments, a heart transplantation for a 9-year-old Linoy from Sderot who's waited for a heart for 6 months. So we have to rush back, some of them, not me, some of the Talpioneers here, but before we do it and conclude the evening, I want to ask the Talpioneers to take a leadership drill. So be very focused. The 6 Talpioneers who performed will stand in the first line for both sides. This is a leadership drill. And all the Talpioneers in the hall will stand behind them. Do it very, very easily and carefully, but we have 2 minutes to take the picture. Okay? So let's begin. תודה רבה.